I'm pleased to introduce our speaker today, Dr. Mark Haas. He is a professor of pathology, renal pathologist from Cedars-Sinai Medical Center. So Dr. Mark Haas, he went to medical school at Duke University and also graduate school at the same institution. And then he had his anatomic pathology residency training, followed by renal pathology fellowship training at Yale University. And he stayed on as assistant professor for several years. And then he moved to the University of Chicago. And then later on, he moved to Johns Hopkins, stayed there as full professor. And then since 2009, he moved to Cedars-Sinai Medical Center in Los Angeles. That's where I had my renal pathology fellowship training. So he has published more than 150 peer-reviewed articles and more than 30 invited articles, comments, or reviews. And he is past president of Renal Pathology Society. He's also the chair of research committee of Renal Pathology Society, and he is recipient of Jacob Churg Award for his outstanding contribution in renal pathology. And he's on multiple journals, editorial boards, and including Kidney International and American Journal of Transplantation, among others. Okay. He has published in almost all the GN and then transplant pathology. So we are very happy to invite Dr. Haas. He has been traveling, and he is invited to give talks nationally and internationally. So we are very happy to have him today in our short springtime to give 2 talks, actually. So this is the first talk on IgA nephropathy. And today at 4 o'clock at the Transplant Center, he's giving a talk on update on BENF classification of renal transplant pathology. Okay, welcome, Dr. Haas.
Thanks, Li-Hong, for that very kind introduction. Thank you for inviting me. It's a pleasure to be here, and I'm glad I missed the snow by a week. And thanks to everyone for being here at this early hour. So I'm going to talk about IgA nephropathy, which is a primary glomerular disease, which is an uncommon disease, but among primary glomerulopathies, it's probably the most common of the primary glomerulopathies seen in the world. These are my disclosures that help me offset the high cost of living in Los Angeles. So IgA nephropathy is characterized by glomerular deposition of IgA detected by immunofluorescence or immunohistochemistry, typically and most prominently in the mesangial. And so how does this IgA get there? I will talk about that a little bit later, but what are the consequences of this IgA deposited in the glomeruli? Well, IgA nephropathy is not, as some people might read in older textbooks, a benign disease. And the 10-year renal survival varies around the world due to largely renal biopsy practices. In Japan, they will biopsy patients through a routine screening program if they have abnormalities in their urine, even hematuria, and they pick up a lot of mild IgA nephropathies. In North America, on the other hand, where biopsies tend to be more limited to patients who have some degree of renal insufficiency or proteinuria, the 10-year renal survival is in the range of about 70%. So a lot of patients with IgA nephropathy will progress to end-stage renal disease. Patients with IgA nephropathy can occur at any age. In childhood, this typically presents with macroscopic hematuria and actually what's called synpharyngeic macroscopic hematuria. So frequently together with an upper respiratory infection. This differentiates this from, say, a post-streptococcal glomerulonephritis, where the hematuria tends to occur several weeks after the infection. In adults of working age, the most common presentation are asymptomatic urinary abnormalities, hematuria and proteinuria, picked up on a routine physical exam. And this is also the case in older adults, although many older adults will present with considerable renal insufficiency, either chronic or acute, due to the fact that they have underlying renal disease due to hypertension or diabetes and less renal functional reserve. Well, how does the IgA get to the mesangium? This is the structure of one of two forms of IgA that are present in humans. We have two forms of IgA, IgA1 and IgA2. And where these differ is in this hinge region of 18 amino acids between the FAB and FC fragments. And this hinge region is present in IgA1. It is not present in IgA2 and contains several amino acids that are O-glycosylated. Because this hinge region is absent in IgA2, and the disease of IgA nephropathy involves abnormalities in IgA1, it's been difficult to develop animal models because mice, rats, and other small animals tend not to have any IgA1. They have only one form of IgA, and that resembles the IgA2. But where the abnormality is in the IgA1 in humans is that there is abnormally low glycosylation, or more correctly, galactosylation of these amino acids in the hinge region. And the IgA that is deposited in the glomeruli in patients with IgA nephropathy is almost exclusively IgA1, and it tends to be polymeric IgA1, where the chains are joined by this short stretch of amino acids known as the J chain. There is a little bit of IgA2 sometimes deposited, and this is probably in the form of autoantibody, which I'll get to in a minute. But patients with IgA nephropathy, as well as those with IgA vasculitis, also known as Henoch-Schönlein-Purpura with nephritis, have increased levels of IgA1 that is under-galactosylated. Now, first-degree relatives may also have under-galactosylated IgA1 with no signs of renal injury, so the defect in IgA1 itself is not entirely sufficient to produce IgA nephropathy, and other events have to happen. So this experiment that was done many years ago, well, 10 years ago now, using a lectin that recognizes the undergalactosylated form of IgA1, shows that this is present in the serum of patients, but not in control patients. And the consequences of this is that this abnormally galactosylated IgA1 is an autoantigen, and you form autoantibodies against this abnormal IgA. And these autoantibodies, which may be IgG autoantibodies or IgA autoantibodies, form in the serum and get deposited in the mesangium. And the levels of these antibodies, as shown by this experiment, by this study, go back, by Berthoud in France, correlates that if you have more of this autoantibody, correlates with a renal risk score of developing progressive renal disease. So low levels of antibodies are not correlated with an increased risk of disease, and then higher levels of these antibodies correlate with an increased risk of developing renal dysfunction. Now, what happens is when these autoantibodies bind to IgA, the abnormal IgA in the serum, there is formation of immune complexes. And these immune complexes then bind to the mesangium. And the primary mechanism for their binding appears to involve transferrin receptors, or CD71, which is expressed on mesangial cells. And abnormally galactosylated IgA has a high affinity for these transferrin receptors. In fact, a much higher affinity than typical normal IgA1. And we can see here mesangial binding in terms of IgA1, and this hypogalactosylated IgA has a much stronger affinity to bind to mesangial cells than normal IgA1. When the immune complexes bind, this produces mesangial cell proliferation. There is then greater expression of transferrin receptors on the mesangial cells. So sort of a vicious cycle, whereas binding of the immune complexes to the transferrin receptors increases surface expression of the transferrin receptors and more IgA binding. These transferrin receptors contain these immune complexes can bind macrophages, which can produce inflammatory cytokines, can lead to secretion of matrix molecules, collagen binding, and ultimately fibrosis within the glomerular tuft. So to summarize from this review that was published a few years ago, the abnormally galactosylated IgA1 is an autoantigen. Antibodies are formed against it, both IgA and IgG antibodies, that form immune complexes in the serum. These immune complexes can bind soluble Fc receptors and macrophages. They deposit it in the mesangium by binding to transferrin receptors and elicit an inflammatory and ultimately a fibrotic response. So the pathology of IgA nephropathy. There is not one typical morphologic appearance of IgA nephropathy. IgA nephropathy can pretty much look like anything by light microscopy. It can look histologically normal. More often there's proliferation or hypercellularity within the mesangial areas, but there can be endocapillary hypercellularity obstructing glomerular capillaries. There can be sclerosis within the glomerular tuft, and there can even be crescents indicative of very severe glomerular injury. So all of these can be seen in this wide spectrum of IgA nephropathy. But where all of these are similar is that they all show dominant IgA deposition within the glomerulus. There can be IgG and IgM. Typically the IgG is in the form of the autoantibody, and the IgG was actually described together with the IgM in the original description of this disease by Berger back in 1968, but the IgA is dominant. C3 is almost always present with a similar distribution to IgA. C1q is typically absent, and IgA does not activate complement by the classical pathway. C1q, being a component of the classical pathway, is absent. In some cases, C4 may be present, indicating activation of the lectin pathway, and I'll talk about this as I'll go on. Because IgA nephropathy has so many widely variant histologic appearances, there have been a number of different efforts to classify IgA nephropathy based on its morphology and correlate this morphology with progression of disease. And there have been many classifications over the years, and the most recent and most widely accepted of these that's currently being used is called the Oxford classification, which was developed over a 5-year interval between 2004 and 2009. And both the first and the last meetings were at Oxford University in England, and that's why it's called the Oxford classification. And the leader of this effort was Ian Roberts from Oxford. And this defines 4 different histologic lesions that are pertinent to the clinical course and outcome of IgA nephropathy. First of these is mesangial hypercellularity, more than 4 cells per mesangial area within glomeruli, and if more than 50% of the glomeruli on the biopsy show mesangial hypercellularity, this is termed an M1, less than 50% M0. Endocapillary hypercellularity, where there is obstruction of glomerular capillaries by cells within the capillaries that can be proliferated mesangial cells impinging on the capillary, or more commonly leukocytes, occluding this glomerular capillary, very similar to the glomerulitis lesion that we see in transplantation. If this is present in any glomeruli, this is termed an E1. If it's absent, E0. Segmental glomerulosclerosis in 1 or more glomeruli involving part but not all of the tuft is termed an S1. If there is no segmental glomerulosclerosis, this is an S0. And then tubular atrophy and interstitial fibrosis, which, if present in less than 25% of the cortex, is termed a T0, 26 to 50% T1, and if greater than 50%, as assessed here on this trichrome stain, which stains collagen blue, T2. And the reason that the Oxford classification includes these features is that when all of the biopsies, it involved the original study involved about 300 biopsies from 4 different continents, and they were each graded by 5 different pathologists. And when this study was done and then correlated with 1, reproducibility, 2, clinical outcomes, and 3, independence from other variables, these were the variables that washed out as being clinically significant and reproducible. In a multivariate analysis that not only included the pathologic features, but also clinical features known to affect prognosis in IgA nephropathy, renal function at the time of biopsy, and mean arterial pressure and proteinuria during follow-up. And each of these scores, the M score, the S score, and the T score, were predictive of 1 or both of these outcomes, either the rate of renal functional decline or survival, or 50% from a renal failure, or a 50% drop in estimated GFR. And we can see that the M score was predictive of this composite outcome. The S score was predictive of the rate of renal functional decline, and the tubular atrophy interstitial fibrosis, the T score, was actually the strongest predictor of both of these outcomes. Endocapillary hypercellularity, by contrast, was not predictive of these outcomes, but when the data were broken down into those patients who did and did not receive immunosuppressive therapy, patients with endocapillary hypercellularity showed a wide difference in terms of their rate of renal functional decline, whether or not they were given immunosuppression. So patients who had the E lesion but did not receive immunosuppression had a rather rapid renal functional decline compared to those who were, suggesting that endocapillary hypercellularity might be a lesion that is responsive to immunosuppressive therapy, and thus this was added to the scores, giving this MEST classification, or MEST, as the Oxford classification is otherwise known. Since its publication in 2009, there have been many validation type studies of this classification, and at least by univariate analysis, they have all found that the M, S, and T scores were predictive of these various poor renal outcomes, although by multivariate analysis, there has been considerably less agreement except with regard to tubular atrophy and interstitial fibrosis. And why might this be? Well, there have been certainly different entry criteria in the different studies, and perhaps they weren't studying the same population that were being studied in the original Oxford group. The original Oxford study and most of the validation studies that used, and some of the validation studies used exclusion criteria that excluded patients with a rapidly progressive clinical course or a high degree of renal failure at the time of biopsy. So anybody with an eGFR of less than 30 or less than about 30% of normal renal function at the time of biopsy, or any patient that was excuse me. My Marco Rubio moment. But anyway, any patient that progressed to end-stage renal disease within a year of biopsy were excluded from these studies, whereas other studies used much more inclusive criteria. And it is for this reason we think that crescents were not found to be a significant predictor of outcomes in the original Oxford study. Crescents are typically accepted as a measure of severe renal injury, and in fact, when I read a biopsy with a glomerulonephritis and I'm asked, questions by the nephrologist at the other end of the phone line, the first question they typically ask are there any crescents? And I had a hard time explaining to them for the first several years of the Oxford classification that crescents weren't predictive of outcomes in IgA nephropathy. So why are you asking about crescents? Why aren't you asking about tubular atrophy and interstitial fibrosis? Well, that's not sexy. Crescents are sexy. But in some other studies that were included in these validation studies, crescents were in fact predictive of end-stage renal disease. But these were studies that included patients who had low eGFRs and rapid progression. And in fact, in this study of Japan, from both adults and children, crescents were a significant predictor of end-stage renal disease in those patients who did not meet the original Oxford classification criteria, but were not predictive of end-stage renal disease in those who did. So because of this confusion about crescents, we formed a crescent working group within the original Oxford group of pathologists and nephrologists, studying 3,096 patients that contained not only data from the original Oxford classification group, but also the Valiga study, which was a large European study, and 2 large Asian studies. And we combined the data from these and looked at the effect of cellular and fibrocellular crescents on renal outcome. And these are the data from this study, which was published last year, showing that any crescents were seen in about 1/3 of patients, but that large numbers of crescents, that is more than 1/4 of glomeruli, were fairly uncommon. Most of the patients had relatively small numbers of crescents. when we looked at the data from the study in terms of the original Oxford variables in all patients in a multivariate determinant of survival from a composite endpoint of end-stage renal disease or more than 50% decline in estimated GFR, we can see we were able to reproduce the original Oxford results with M, S, and T being predictive of poor outcomes, but only the T variable actually remained significant in patients who were given immunosuppression. When we added crescents, that is any versus none, to the analysis, crescents were also significant in all patients and those who were not immunosuppressed. But again, this effect of crescents on outcome was lost in patients given immunosuppression. And the effect of crescents on the outcome was progressive with an increased number of crescents. So as we look here at all individuals, patients who had any crescents had a worse outcome. If they had crescents in only 10% or fewer of the glomeruli, they were here. Whereas if they had crescents in more than 25% of the glomeruli, they had even a worse outcome. Similar results in patients not given immunosuppression, but this entire relationship between the fraction of crescents and outcome was lost in patients who were given immunosuppression. And this is perhaps better illustrated here, whereas this vertical axis is the axis of significance with the hazard ratio for a combined event of end-stage renal disease or greater than 50% of outcome. If the risk is significantly greater than 1, then the line does not cross this axis and is a significant predictor of this combined event. And we can see that any versus no crescents, both all patients and patients who did not receive immunosuppression had a significant impact on their outcome that was lost in patients who were given immunosuppression. Similar findings in patients who had crescents in less than 25% of their glomeruli. But in patients who had crescents in 25% or more of the glomeruli, this was a negative predictor of outcome regardless of whether these patients were immunosuppressed or not. So the new Oxford classification that was published very recently in Kidney International now includes a C-score, C0, no crescents, C1, crescents in less than 25% of the glomeruli, identifying patients at risk of poor outcome if not given immunosuppressive therapy, and then C2, identifying patients at risk of a poor outcome whether or not they are treated with immunosuppressive therapy. More recently, Ian Roberts and his colleagues have studied in more detail this S lesion or segmental sclerosis lesion. And what they did is they identified 2 histologic types of this S lesion that look quite different by light microscopy. There were these lesions in which there was sort of this bland scar, usually with a capsular adhesion. And there were these other lesions in which there was a cap of swollen appearing podocytes overlying the sclerotic segment. From studies with focal segmental glomerulosclerosis, this lesion looks an awful lot like primary FSGS, a podocytopathy in which there is injury to the podocytes leading to proteinuria. Whereas this lesion is more typical of what we might see in inflammatory forms of glomerulonephritis that have burned out. sort of a typical post-inflammatory scar. And Ian and his colleagues studied whether there is a difference in terms of the outcome in these two groups of patients within the S lesion in terms of their treatment. And when looking at patients with S0, no segmental scars, they did not find any effect of difference in terms of outcome, whether or not the patients were treated with immunosuppression. And similar for patients with S1 lesions with the post-inflammatory scar. But when these F1 lesions were associated with podocyte hypertrophy and capping, we can see that these patients did better when treated with immunosuppression, potentially identifying yet another group of IgA nephropathy patients that does better when treated with immunosuppression. A point of contention within IgA nephropathy has been vascular lesions. What is the effect of vascular lesions on the prognosis of IgA nephropathy? In the vast majority of studies that have been done, vascular lesions, particularly arteriosclerosis and arteriolosclerosis, were not found to affect the prognosis of IgA nephropathy. But there have been a small number of studies that have looked at one other vascular lesion that seems to potentially have an impact. But this is still in the controversial stage. And this is thrombotic microangiopathy, where one sees changes of thrombosis within the glomerular tuft or within the small vasculature, mainly the arterioles. The earliest study of TMA in IgA nephropathy was done by Tony Chang and Charlie Alpers in Seattle when Tony was a fellow in that lab, now doing very well at the University of Chicago, where they studied 435 cases of IgA nephropathy that were diagnosed in this interval, and they found that TMA was quite rare. Less than 3% of the biopsies showed TMA by light microscopy and electron microscopy. All 10 of these TMA patients had hypertension. 6 had evidence of malignant hypertension. 3 others had diastolics greater than 100. Half had nephrotic range proteinuria, and of those that were followed, 7 out of the 8 had very poor outcomes. 6 of the 8 developing end-stage renal disease, and 1 other essentially having end-stage renal disease at the time of biopsy. Then there was this paper that came out a few years later in 2012 that gave very different results. And this is a French study from Paris looking at 128 patients, and they found that about half of them had lesions of thrombotic microangiopathy on their biopsy, compared to about 3% in the Seattle study, although only 8 of these patients had laboratory evidence of TMA. But unlike the Seattle study, which studied both light microscopy and electron microscopy, which can be quite helpful in diagnosing TMA, this study studied only light microscopy and defined TMA by reddish staining on a trichrome stain. Now, at least in my experience, one can see reddish staining on a trichrome stain in hyalinosis lesions, say in diabetic nephropathy. So this went through various rounds of review in Kidney International, and I was one of the reviewers, and 3 times I recommended rejection of this paper, and shows how much influence I had with the editors of Kidney International because they published it anyway. Most of these patients were hypertensive. Some had malignant hypertension. And these are illustrations of the TMA lesions that were taken from this article. And here we see a thickened arteriole here and a thrombosed arteriole. Certainly, I will accept this as a thrombotic microangiopathy. Here's another thickened arteriole, but unlike this very bright red staining, this has kind of a more darkish, reddish staining, very thickened and completely occluded arteriole. Here's one that is very thickened and hyalinized with a slight bit of reddish staining. And here's one with some peripheral nodular hyaline of the type that we tend to see in calcineurin inhibitor toxicity in transplants. So while I will certainly accept this for a TMA, and this as possibly a maybe, these are not thrombotic microangiopathies. Nonetheless, they found that morphologic TMA was associated with worse renal outcomes. However, this simply might be that these patients were very severely hypertensive, and hypertension is a known negative prognostic indicator clinically in IgA nephropathy. Those small number of patients who had, I think it was 8, had clinical and morphologic evidence of TMA in their serum, had a rapidly progressive renal course, and these patients probably did in fact have a true TMA. And finally, there's this study from Beijing, which has been now presented only in abstract form, but seems to be somewhere in between the two, but a little bit closer to the Seattle study, in which they found that 19 patients out of 985 had TMA lesions in biopsies studied not only by light microscopy and immunofluorescence, but also by electron microscopy. This was also associated with higher blood pressures, more severe proteinuria, worse renal function at biopsy, and a higher likelihood of reaching this composite endpoint of ESRD, or at least 50% rise in eGFR or death, and was an independent predictor of this endpoint in a multivariable analysis that included the Oxford MEST-C scores. And in this particular case, they look here at renal survival, or more correctly, survival from this composite outpoint in the absence and presence of TMA, and that TMA was predictive, but simple arteriolosclerosis lesions were not predictive of this endpoint. I'm going to talk a little bit about complement in IgA nephropathy, which I think is an emerging field in a lot of different glomerular diseases. I think with the sort of discovery of C3 glomerulonephritis as glomerular diseases with a membranoproliferative pattern caused by abnormal regulation of complement, and specifically of the alternative pathway of complement, there's been a renewed interest in complement in terms of glomerular diseases, and this has extended to IgA nephropathy. Now, the mesangial IgA deposition in IgA nephropathy results in complement activation by the alternative pathway, and in some cases, by the mannose-binding lectin pathway, is indicated by about 30% of these biopsies showing C4 deposits in the absence of C1q. This is an old study just looking at complement and other components, immune reactants seen in different forms of glomerular diseases, and we can see here that some but not all of these patients had C4 deposited, most had C3, and those that had C4 also had deposits of mannose-binding lectin. This is a study from the Netherlands, from Mo Daha's group, which has done a lot of work on complement in glomerular disease, and looking at mannose-binding lectin staining within the glomeruli, and they found 15 out of 60 cases were MBL positive, and C4D staining within the glomeruli by immunohistochemistry was mirroring this MBL staining. So what's the impact, if any, of activation of the lectin pathway in addition to the alternative pathway? Well, in a follow-up to this study, they found that patients who were MBL positive tended to have more proteinuria, tended to have more glomerulosclerosis, and tended to have more interstitial fibrosis and interstitial inflammation than those patients who were NBL negative. In another more recent study from Spain, looking at C4D deposition within the glomeruli, C4D deposition was indicative of a worse renal survival by a univariate analysis and also by a multivariate analysis, including the Oxford classification. And that C4D staining, as well as these Oxford parameters, were indicative of an increased risk of developing end-stage renal disease. And so there's now actually, I saw at the ASN, a clinical trial going on of a new experimental drug that's just starting that is a specific inhibitor of the lectin pathway in IgA nephropathy. Unfortunately, when I spoke to the people from this company, they're probably not doing the study exactly right because they're not actually looking at these biopsies for lectin pathway activation. They're just testing all comers. And since only about a quarter to a third of patients with IgA nephropathy have evidence of lectin pathway activation, there's a good chance that their data are going to get watered down and that they won't see a significant effect, and their study will be highly underpowered. And actually suggested, well, maybe you might want to do some C4D staining on your biopsies to at least test those, to see if those patients who have evidence of lectin pathway activation are more responsive to the drug than those who aren't. But that's what happens when sometimes when people who do clinical trials don't really understand the disease they're studying, apparently. There's also some very new data looking at alternative pathway activation in IgA nephropathy, and this comes from the group in London, from Matthew Pickering and Terry Cook, who have studied C3 glomerulopathy quite extensively. And their major interest is complement factor H. And complement factor H is a negative regulator of the alternative pathway of complement. And so factor H sort of puts the brakes on the activation of the C3 convertase. There are also factor H related proteins, 1 and 5, which antagonize the ability of factor H to regulate complement when it's deposited on the surfaces. And these investigators examine correlations between the levels of these different complement regulatory proteins and parameters of disease activity in IgA nephropathy. And what they found was that high levels of this complement factor H1 associated protein, higher levels were associated with lower GFRs in this patient population, whether they had 1 or 2 copy numbers of this complement factor H regulatory protein. Furthermore, in a study that was published in the same issue of Kidney International from a Spanish group, they found that the progression of disease here, defined as a doubling of baseline serum creatinine, was greatest when both there was C4d positivity and low factor H related protein 1. So abnormal regulation of the alternative pathway together with the activation of the lectin pathway seem to have an additive effect in promoting disease progression in IgA nephropathy. And finally, I'm going to end with a little bit of information for the diagnostic pathologists amongst you, and that is a little bit about the differential diagnosis of IgA nephropathy. There's not a lot of diseases that give you IgA deposits in the glomeruli. There's IgA nephropathy, and there are primary forms, and there are secondary forms mainly related to chronic liver disease. There's IgA vasculitis, or Henoch-Schönlein purpuranephritis, which about 40 to 50% of cases involves the kidney, and the nephritis is indistinguishable from IgA nephropathy on a biopsy. The distinction has to be made on clinical grounds. And then there are a number of other lesions. Lupus nephritis is characterized by a full house of immunoglobulin and complement components, IgG, IgA, and IgM, but patients with lupus nephritis have classical pathway activation, so they have a lot of C1q in their glomeruli, and usually these patients, if they have proliferative glomerulonephritis, will have clinical and serologic evidence of lupus. One of the more important differentials is a lesion called IgA dominant post-infectious glomerulonephritis, which is mainly a post-staphylococcal as opposed to a post-streptococcal lesion. Now, when you see acute post-infectious glomerulonephritis, whether it's post-streptococcal or post-staphylococcal, that's very easy to differentiate from IgA nephropathy by simple light microscopy. This is an acute post-infectious glomerulonephritis. This was actually a lesion that a few years ago I was called in to diagnose a patient with acute renal failure who had a biopsy on Thanksgiving Day, and this is what the biopsy showed. And it was like, okay, this is acute post-infectious glomerulonephritis, enjoy your turkey. And when we ultimately did electron microscopy on this biopsy, it showed these typical large subepithelial humps of post-infectious glomerulonephritis. But as post-infectious glomerulonephritis heals, the neutrophils tend to resolve, and the endocapillary proliferation declines, and what you're left with after a couple of weeks is mainly a mesangial lesion that can look an awful lot like typical IgA nephropathy. And if this lesion is IgA dominant, how can one differentiate this from just IgA nephropathy, since this is usually a self-resolving lesion, and in children and in adults it may require some degree of immunosuppression to treat. By immunofluorescence, one can sometimes get a little bit of an idea. Here we see a lot of mesangial deposition of IgA, but we also see this sort of coarse granular staining out in the periphery in the glomerular capillaries, suggesting that maybe these are some residual subepithelial humps. But this is not entirely specific, but electron microscopy is quite helpful because what we actually do see by EM is the residuum of these subepithelial humps. We see these partially reabsorbed, so they're not really particularly electron dense at the time, but more electron lucent. These resolving subepithelial humps, and they tend to hide out in these mesangial notch or waste regions between adjacent glomerular capillaries, perhaps because the cells that are involved in their reabsorption have have less access to these here. And actually, this is something that was actually pointed out in the first edition of Heptonstall's textbook, which was published back in 1957. So you can even sometimes learn from things that are over 50 years old. And this is actually quite helpful in distinguishing this. There's actually a new antibody that just was published in Kidney International called KM55, which is an antibody to the abnormally galactosylated IgA. It would be interesting to know if patients with post-infectious forms of IgA-dominant GN have or do not have this abnormally galactosylated IgA. If they don't have it, this would be another potential tool in our arsenal in the differential diagnosis. Perhaps more importantly, though, are these mixed lesions, and particularly IgA nephropathy in association with ANCA-associated glomerulonephritis. This was a biopsy that I was sent for a second opinion on a number of years ago that was diagnosed as crescentic IgA nephropathy. And it had crescents in about 70% of the glomeruli. From what we know about crescentic IgA nephropathy, when you have that many crescents, this is not a patient, if this is an IgA nephropathy, who's going to respond to any kind of immunosuppression. This is a patient who's going to progress rapidly to end-stage renal disease. But this is what the biopsy looked like. Sure enough, it had plenty of mesangial IgA, and it had necrosis within the glomerular tufts and cellular crescents. But look at the part of the glomerulus that's not involved by the crescent. It looks totally normal. This has been termed by a number of groups bland necrosis. And the differential diagnosis of bland necrosis is ANCA disease and anti-GBM disease. If you have immune complex disease, whether it be IgA or lupus or post-infectious or whatever, that's severe enough to give you necrotizing crescentic lesions, one should see some mesangial and endocapillary hypercellularity. In the absence of such hypercellularity, this is ANCA disease, most likely, especially if there's no IgG in the glomerulus, which there wasn't. Asked them to do an ANCA, and the patient was actually anti-PR3, strongly anti-PR3 positive. So this was a patient who could potentially respond to immunosuppressive therapy, as Dr. Nachman and others have shown. ANCA disease, unlike crescentic IgA nephropathy, tends to respond to aggressive immunosuppressive therapy with frequent remissions of disease, although unfortunately relapses are still pretty common. So if we look at, again, in ANCA-positive disease, we see this so-called bland necrosis, where you see necrosis within the tuft, and the remainder of the tuft and the uninvolved glomeruli look normal, whereas in ANCA-negative disease, when we see necrosis, in this case an IgA nephropathy, the tuft is much more cellular. And with that, I will conclude and take some questions. I don't know if you have IgA supermarkets here. It's usually in smaller towns around the country, mainly on the East Coast. But it's assured quality since 1926.
Mark, that was a great overview. Thank you so much. I really enjoyed that. As you know, nephrotic syndrome is relatively rare in IgA, but there are certain patients who definitely have nephrotic syndrome. Your one slide indicated that this does happen occasionally. In looking at the EM on those patients, are you able to predict the degree of nephrotic syndrome and whether or not they're going to have nephrotic syndrome by EM and looking at podocytes?
Usually not by EM. I mean, there's a subset of patients with IgA nephropathy who have fairly normal histology, and they have diffuse foot process effacement. And those patients behave like minimal change disease. And there was a series that was published out of Columbia not that long ago. And they behave like minimal change disease, and they often have steroid-responsive nephrotic syndrome. If you see most nephrotic syndromes in patients with IgA nephropathy are associated with either endocapillary hypercellularity, segmental sclerosis, or both. So it's very rare to see nephrotic syndrome in IgA associated with just a purely mesangial proliferative lesion. So if you see nephrotic syndrome, then it might be a concurrent minimal change disease. But the degree of podocyte foot process effacement especially is quite variable. And sometimes we'll have patients who have 4 grams of proteinuria and endocapillary hypercellularity and maybe only 50% foot process effacement. So I've never actually systematically tried to study the correlation, but just off the top of my head, it doesn't seem to be very tightly correlated.
There might be one group who really became 55 staining.
Yeah.
I have a feeling the so-called IgA plus minimal change,
Yeah.
Confusion, I'm sure TN 55
Might help differentiate those, yeah.
I have when you look at the biopsy of IgA nephropathy, you are struck in a given section. I'm talking about the disparity between mesangial deposition of IgA and light histology.
Yeah.
In a given section, mesangial deposition IgA is usually homogeneous from glum to glum, whereas mesangial hypercellularity is all over the place. So one glum may look completely normal, next one shows.
And they both show similar amounts of IgA. I mean, the amount of IgA seems to be related to just the amount of IgA containing immune complex, and presumably what happens after that determines what's going to happen to the glomerulus. If there's if there's immune complex binding, if there's complement activation, etc. Why this is different from glomerulus to glomerulus, we don't know, but it's certainly not something that's, just common to IgA nephropathy. I mean, we see focal lupus nephritis, where we see, where presumably the glomeruli are all exposed to the same level of antigen. But you have some glomeruli that look totally normal, and some glomeruli that have active proliferative and crescentic lesions. Yet if you do immunofluorescence, there's immune complex in all of them. In ANCA disease, there are glomeruli that have florid necrotizing crescentic lesions, and there are some that look absolutely normal by light microscopy, and yet they're both exposed to the same level of circulating ANCA. I mean, why there's this heterogeneity in terms of the glomerular appearance in all of these diseases, we really don't know. I mean, is there somehow different access? There's been a suggestion that perhaps some glomeruli might have greater activation of regulators that might downregulate some of the inflammatory mediators, such as complement regulators. But at this point, it's really not known why some people get diffuse disease and some people get very focal disease, and yet there's immune complex in all of the glomeruli in people who have focal disease.
So that makes me wonder, maybe the mechanism for the deposition and the injury and the glomerular response maybe are two different.
Yeah, no, there clearly is, and there clearly is, and as I mentioned very early on, about half of first-degree relatives of people with IgA nephropathy have abnormally galactosylated IgA, and they have IgA in their mesangium. In fact, about 4% of the general population will have IgA in their mesangium, yet they don't have an inflammatory glomerulonephritis. Why are these folks less likely to develop GN than others? Well, maybe it's some kind of a complement abnormality that needs to be concurrent, that if you have activation of the lectin pathway, and if you have certain alleles in your alternative pathway, and various other things that serve to activate the inflammatory process once the IgA gets deposited. The IgA itself is required but not sufficient for the glomerulonephritis.
Thank you very much, Dr. Haas.
Yeah.
Interesting presentation. So regarding the C1q and the role of C1q, I'm not sure that we actually can ignore. It may still have a role. It may not be a direct role by direct activation of C1q deposition, although it is very difficult to actually demonstrate the deposition of C1q as it is a very unstable protein. But an indirect mechanism would be, because there were several more recent studies that show that IgA nephropathy and the disease severity actually correlates with presence of antibodies against C1q. It may be because C1q is not able to be reduced in concentration to clear the IgA immune complexes. So C1q may still play a role.
Yeah, no, I can't rule it out. And a lot of these deposits, even if IgA is not activating the classical pathway, it's very frequent to see. I mean, there are these autoantibodies, these IgG and IgM autoantibodies that can bind within the immune complexes. If they're the right subclass of IgG, if we're talking about IgG1s and IgG3s, they can certainly activate classical pathways. So there may be sort of secondary ways of activating classical pathway, and it's usually absent, but it's not always absent. It's usually there, when it's there, it's usually in small amounts, though, 1+, trace to 1+. But, and at least there's been one study that showed it does seem to correlate with IgG and IgM in the glomeruli.
Thanks very much.
Thank you.